All right, this is a short voiceover regarding nutrition from Potter and Perry. So some of the guidelines that you need to be familiar with, nutritional guidelines, Healthy People 2020. They're updated recommendations from Healthy People 2010. The U.S. Department of Health and Human Services sets nutritional goals and objectives for the American people. These goals are to promote health and reduce chronic disease amongst all individuals in the U.S. Some of the challenges with these guidelines is that consumers are not motivated to put them into practice. So if you looked in Potter and Perry, you're going to see a list of some of these recommendations and goals, and I think a lot of them make sense. So reducing the obesity epidemic, not only adults but children. Reducing iron deficiency anemia in our pregnant individuals throughout the duration of their pregnancy and the postpartum, and even in young children. Increasing a choice of healthy foods in schools and work sites. And then also improving food security with some of those individuals with low socioeconomic status. So some other guidelines are the Choose My Plate. It's a food guideline that's set by the U.S. Department of Agriculture, and it replaces the old food pyramid. Okay? So really, the Choose My Plate is a basic guide for making healthy lifestyle choices. So some of the key components to Choose My Plate, obviously, is balancing your calories, decreasing portion size, increasing overall water content through the day, and then decreasing simple sugars, overall fat content, trans fats, saturated fats, and then reducing sodium, eliminating sodium throughout the day and the things that you drink and eat. So let's just do a review over basic essential nutrients. So carbohydrates, right? We know they can be broken down into simple and complex saccharides. It's our main source of energy. It's the most essential or efficient source of energy that we can use for cellular metabolism, energy production. So our calories, each gram of carbohydrate produces about 4 calories. And if we broke it down into examples of food choices, we know our simple carbs come from sugars, soda, candy bars, white bread. And then our complex carbs, barley, cereals, grains, oats. So proteins, we know they can also be utilized for energy production, but it's not an efficient way, for fuel. But we can use it in situations of starvation, increased metabolic rate, patients in the hospital who are sick, have an injury, illness. But overall, proteins are necessary for growth, maintenance and repair of body tissue, increase muscle mass. Calories provides about 4 calories per gram of protein. And some of the food choices, we know we can break proteins down into complete proteins and incomplete proteins. So some of our complete proteins come from fish, chicken, red meats, even soybeans. And then some of our incomplete proteins come from beans, legumes, some of our vegetables. Fats, we know we can break it down into saturated, polyunsaturated, and monosaturated. We also can use fats for an energy source, but we know it's more responsible for insulation, organ protection. We can use it for the absorption of fat-soluble vitamins and hormone production. And we also need lipids, fats, for nerve transmission throughout our synapses. So fats does have an important role in our body, just not in large quantities. So we know it's caloric dense, it's dense calories. So a gram of fat is equivalent to 9 calories. That's an important component to remember. So if we looked at saturated fats, animal fat products like animal meats, especially with white streaks throughout it, lard. Some of our monosaturated, where we know we want increased intake of that throughout the day, are olive oils, nuts, avocados. So water, we know in a healthy individual, adult makes about 60 to 70% of total body weight. We know our younger children, infants, and even our older adults, we know water content as far as total body weight alters in the infants and the older patients. And so as a result, we know even small amounts of water loss in these individuals can lead to dehydration, especially a little bit more quickly than the average healthy adult. So we know fluid intake comes from multiple sources, not even just what we drink. It can come from fruits, vegetables. In a healthy individual who doesn't have renal or cardiopulmonary disease, we know that what we intake, whether it's our fluids, foods, should always equal what we output. So within our urine and some of our insensible losses through respirations, sweat, diaphoresis. So fluid intake should always match fluid output. Obviously there's going to be an increased water intake need with our patients who have a higher metabolic rate if they've got a fever, an infection right after surgery. So these patients are always going to need an increased water intake. Where we become concerned if these patients truly do have a cardiopulmonary disease or end-stage renal where they're on dialysis, we have to be careful and restrict these patients depending on their needs based on physician orders. An average amount of water intake for a healthy individual should be between 1,500 milliliters to 2 liters per day. And then we know vitamins. We've got fat-soluble and water-soluble vitamins. We know they're not synthesized in the body. They come from fresh foods, fruits, vegetables, some of our meats. We know that fat-soluble vitamins, we need fat for their absorption, for us to be able to absorb it, to utilize them. In some situations where we don't have appropriate fat intake or we don't have bile salts to break down fats, we're not going to be able to absorb and utilize fat-soluble vitamins. So there may be deficiencies in some of those patients. So some of our fat-soluble vitamins, I think vitamin A, vitamin D, vitamin K, and then some of our water-soluble vitamins, vitamin B, our B complex vitamins. And so although, priorly you may have thought only fat-soluble vitamins can increase the risk for toxicity in our patients, it doesn't matter. Fat-soluble, water-soluble patients can, take in too much of these vitamins and can have toxic levels. So we need to be aware of that. It's an important component. And so that we also know that if patients are getting, eating a well-rounded diet, that they should be getting most of their vitamins in the foods that we eat. So not everybody needs to be taking fat-soluble, water-soluble vitamins. So factors that can influence nutrition, obviously, are environmental factors. If a patient has a sedentary lifestyle, whether it's their personal or their professional life, we know this is going to alter their metabolic rate. It can affect how much calories they need per day, how much energy they're burning. This could be affected by their work schedule. Do they work long hours where they can't eat well-rounded diets, good nutrition? What's our access to full-service grocery stores that do have access to the fresh fruits and vegetables, the produce sections? And then two, some eating the healthy foods, the more organic, don't have the pesticides that maybe aren't seasonal in certain locations. There's a lot of high cost to the healthier foods. It's a lot easier to eat or to purchase white bread that's on sale, or the snack cakes, chips. And then in certain locations, lack of access to safe places to play and exercise, maybe in some of our inner city schools or inner city locations where the crime rates are high. So some factors that can influence nutrition. And then we're going to always focus on the older adults. So we know as older adults age, their metabolic rate slows. There's a redistribution of muscle mass and subcutaneous fat. So they don't necessarily need to eat as much because of their slower metabolic rate, but they still need the same nutrients, the essentials. We know from talking about with 500 in health assessment, we talked a little bit about their alterations in taste, smell. So not only does this put them at risk for safety issues, it's also going to put them at risk for malnutrition, poor intake, maybe even putting a little bit too much salt and seasonings that have high levels of sodium, MSG, that aren't good for them. If they're living on a fixed income, some of our meats are a little bit more expensive, so you might see these patients eating more carbohydrates versus some of their more complete proteins that they need. So in instances, you might see older adults with iron deficiency anemias, or some anemias that are linked to folic acid deficiencies, B12 deficiencies. And then obviously lack of transportation. If they live alone, if some of their driving privileges have been taken away related to some of the medications they're on, some of the disease process, they may not be able to get to the store as much, so they have to rely on other patients or other people. And poor oral health, definitely. If their dentures aren't fitting, they have mucosal breakdown, irritation. It might be difficult for them to eat. And this may be linked to medications, chronic illness, some of maybe chemotherapy, head and neck radiation. And then we also know depression. If patients are depressed, they're not going to want to eat. So if these patients have lost a spouse, a loved one, maybe they're estranged from their family, so they're not going to want to eat. Sometimes those patients don't want to cook for themselves, or they don't want to eat alone. And so I'm not going to go over each of these specific alternative food patterns in detail, but I think it is important to know that although as a nurse, especially in this program, we're focusing on our required resources that focus on more traditional westernized food patterns, that you're going to come across patients and even maybe yourselves that are intaking alternative food patterns. So what we need to know is to be sensitive to that, to be knowledgeable, but also to be aware that if they're not knowledgeable on ways to make sure they're still getting overall good nutrition, despite some of the things that they're lacking in their diet, that they can be at risk for some nutritional deficiencies, like B12, B vitamin deficiencies, anemias related to those, anemias related to folic acid deficiencies, anemias related to iron deficiency anemias. So it's just essential for us to make sure that they're knowledgeable, making sure they have overall well-rounded nutrition, and that if not, if they're having some side effects from their alternative food patterns, are they taking dietary supplements, and do their physicians or healthcare providers know that they have an alternate food pattern? So some of the assessment that we're going to look at with our patients with, who are at risk for nutritional deficits, we're going to look at their height and weight, but we know characteristically it's the BMI that we're looking at more for our patients. We know that it doesn't necessarily adjust for muscle mass, so sometimes it can be skewed results. But we know we look at BMI as far as risk factors for diabetes, type 2 diabetes. We look at it for cardiovascular risks. Weight changes, a weight loss or weight gain. Was it intentional or was it not intentional? And over how long of a period did it occur? Is it water weight, water loss? And then we're always correlating this to the primary diagnosis, which makes sense. Does the patient have a diagnosis of cancer that's metastatic? Have they just started chemotherapy or radiation? A new medication? Screening tools. We're using tools, assessment tools for everything. So one of the most common ones for nutritional status is the mini nutritional assessment tool, and that can be found under Week 5's handouts. And it just identifies patients who are at risk for nutritional deficits, malnutrition. Some of the laboratory and biochemical tests that we may use to help diagnose a nutritional deficit There's not one specific one, but I think these are fairly common that we're going to see in our patients who are in the hospital or outpatient who we suspect have a nutritional deficit. Obviously, an iron panel, hemoglobin, hematocrit. So is it just related to the iron intake, or is there truly a blood loss? We might look at folic acid. We might look at B vitamins. We can check those. And, we can also look at albumin, pre-albumin. That gives us an essential component to their nutritional state, protein intake. There's a difference between the half-life with albumin and pre-albumin. I think albumin has a half-life of like 20 days, whereas pre-albumin has a half-life of 2 days. So when patients are in the hospital and they're sick, they've had a major surgery with complications and they've been there for long periods of time, or maybe a severe bout of pneumonia with secondary complications to that, we're always going to look at their pre-albumin to assess their nutritional status and their overall protein intake and their needs, because the half-life is so much shorter. So it's a better picture of what's happened currently or presently. Whereas if this patient has chronic issues with poor intake, dietary issues, decreased protein intake, we're going to look at the albumin because it has a longer half-life, and so it's a better reflection of long-term issues, chronic issues. So health history, some of the subjective issues we're going to look at when these patients come in, age, their cultural background, religious food patterns, so that may play into their alternative food patterns. Are there certain meats that they won't take? Is there certain foods together that they won't eat? And their use of any type of vitamin, mineral, or herbal supplement, we always need to make sure that's on the medication administration record. Any over-the-counter drugs. When we look at the patient's physical exam, we're looking at anything that would indicate to us that the patient is dehydrated. They are malnourished. So we're looking at their hair. Is it glossy? Is it full? Their nails, are they kind of spoon-shaped and thin? Okay, brittle. Those are all indications of malnutrition. What's their skin? Is it dry? Is there a glow to it? Or does it kind of have a lackluster shine to it and, just a very dull, kind of grayish color? And their eyes, are they bright? How's their muscle tone? Is it fairly well developed? And so, other things that we can look at. We can look at, their eye orbits. Are they sunken? Do they have a scaphoid appearance to their chest cavity? What's their urine look like? All of those things. Sometimes in our patients who are severely dehydrated and malnourished, their blood pressure might be a little on the lower side. Their heart rate might be high. So the term dysphagia, we know that means difficulty swallowing. There's going to be multiple reasons for dysphagia. I think some of the things that we can think of: stroke, maybe a higher spinal cord injury. Some of our autoimmune or neuromuscular diseases like Guillain-Barré, myasthenia gravis, multiple sclerosis, muscular dystrophy. Some of these patients are going to have issues with impaired swallowing, and we know dysphagia, some of the complications from that: aspiration pneumonia, dehydration, weight loss, malnutrition. All right, so what are we going to do with our patients who are increased risk for dysphagia? Okay. So some of the things we might see in our patients who are having a difficult time swallowing is coughing when they're eating, especially when they're swallowing thin liquids. A lot of times if our patients swallow thin liquids, they can't feel it at the back of their throat. So they might cough with thin liquids, but thicker liquids, thicker substance foods might be easier for them to swallow. Do they have a depressed or abnormal gag reflex? When you do help them eat, or you're watching them swallow their pills, swallowing water or food, is their swallowing reflex, is it delayed? Okay. I think sometimes it's easy to understand. Do they have any drooling, from one side of their mouth? Do they have pocketing? So on one side of their mouth, are they not swallowing at all? So if you go to give them another bite of food or check to see if they've swallowed, you're going to still find food in there. And so obviously the person we're going to be collaborating with is a speech therapist or a speech language pathologist. And so a lot of times if you suspect your patient has dysphagia for whatever reason, the physician's going to write a referral or consult for a speech language therapist assessment. So these patients, they can come to the bedside and do a swallowing assessment. And there might be some other diagnostic testing done with that. It might be like a modified barium swallow. Okay. And these speech therapists are going to be able to, I think, identify to the degree that their dysphagia is, like how severe is it. And they're also going to be able to give recommendations for the types of foods that they should be eating and kinds of things that we should be doing to help make it a little bit more successful for them so that we're not having issues with dehydration, malnutrition. There's some things that we could do for these patients, obviously keeping their head of the bed up as far as we can, giving them some rest periods, so allowing them to have times in between their bites, right? Not pushing them, giving them plenty of time. Sometimes if they tuck their head down and kind of put their chin down in the down position when they're swallowing, believe it or not, this helps them to swallow, kind of reduces their risk for choking, coughing. Place the food on the stronger side of the mouth. It's easier for them to swallow. And putting them on the appropriate diet. Like we said, some of our patients who truly have dysphagia, they can't swallow thin liquids. So putting them on nectar or honey thickened liquids or pureed or mechanical soft foods, depending on what the speech therapist suggests. All right, so obviously our nursing diagnoses, risk for aspiration, right? And like airway, important, right? Feeding self-care deficits, imbalanced nutrition, less or more than body requirements. So some of our therapeutic diets that you'll see in the hospital that you should kind of be familiar with. Clear liquids. They're the type of liquids that we can see right through. So broths, coffees without any cream, popsicles. Okay, those are clear liquids. And you might see those on patients who just came out of surgery. We're going to start them very slow, start them simple, see how they tolerate it, make sure they don't have any nausea, vomiting, that they've got bowel sounds or passing flatus, and then we can advance them. And so some advancements that we might see is full liquid. So these patients can have all clear liquids, and then we can make it a step up. So puddings, frozen yogurt, custards, some cooked cereals like cream of wheat. That might be more appropriate with full liquids. So we said with patients who have dysphagia, some of the diets we might see them on is pureed or mechanical soft. So pureed, believe it or not, we can puree meats, vegetables, and fruits. Patients don't really like it a lot, but when this is all that they've got, they'll take it. Scrambled eggs falls under pureed as well. So mechanical soft, this is going to be finely or ground diced meats, maybe some cottage cheese, and any kind of cooked or soft vegetables, bananas, kind of fall under mechanical soft. Sometimes your patients who come into the hospital, even if they don't have a difficulty time swallowing, but they left their dentures at home, they're missing teeth, mechanical soft and pureed might work for them too. All right. So some of your patients who come in and they have like gastroenteritis, they have got a lot of diarrhea, stomach upset, we might consider putting these patients on like a soft, low residue diet. So these diets don't have a lot of fiber into them. So if you've ever heard of the brat diet, this might kind of fall under that. So applesauces, toast, maybe rice. And then we're familiar with high fiber, right? Our patients who are at increased risk for constipation. But we also know that a high fiber diet is an important component to avoid the development of colon cancer, diverticuli, which we're going to talk about in a few slides. And then low sodium, 4 gram or no added salt. Okay, so there are other variations to low sodium in the hospital as well. So you might see 4 gram, you might see 2 gram, and you also might see something that just says no added salt. And then obviously regular has no restrictions with it. We don't hardly see that in the hospital anymore because everybody has a special diet. So how can we promote appetite in our patients who just really don't want to eat? Okay. So good oral hygiene, right? Making sure these patients mouthwash, oral care with some of the swabs, right? If the patients have a unpleasant taste in their mouth, we're not helping them just with overall good oral hygiene. They're not going to want to eat. Okay, so that's one way to promote their appetite. If they're eating in a hospital, right, it's not a very pleasing environment sometimes. There's smells, there's certain things that are laying around their bedside table in their room. So, making sure like the bedpan, the bedside commode, all of those things are away. Making sure their area is clean, it smells good. That can help promote appetite. Common sense things. Sitting a patient up in chair, or at least sitting them all the way up in bed for meals, is definitely going to be helpful, right? We want them to be in as most routine of a position as possible to increase their appetite. Alleviating their pain, controlling their difficulty breathing, right? Patients, if they're in pain, they're having a hard time breathing, they're not going to want to eat, okay? So make sure they're comfortable. If they need a little bit more oxygen when they're eating, sometimes we see that in patients. What if these patients are on a face mask or a Venturi mask? Put them to a nasal cannula. That's definitely going to help them eat, right? They're not going to be able to eat with a mask. And always allow ample time. Don't be pushing these patients wanting to take their trays. So if you have to assist with oral feedings, always make sure that you're protecting their safety, their independence, and their dignity. So there's kind of a rule of thumb with any of your patients. We want to care for them. Be compassionate. Yeah. So always make sure that you let your patients be as independent as possible. Do as much for themselves as possible, and then if you need to help them at the end, that's fine. But you also need to realize that patients may get pretty messy when they are feeding themselves, especially if they're, recovering from an injury, illness, okay, if they're tired. So give them as much leadway and independence as possible, but just make sure you're kind of helping them at the end, giving them the appropriate devices. If they need some assisted devices to help them eat, they might need a bigger plate, bigger utensils, cups that have a bigger handle on it. Some of your stroke patients who are, recovering, they still have some residuals. We need to make sure that it's individualized to the patient. So letting them do as much for themselves as possible, realizing that they're going to get messy, but it's okay. All right, so what is enteral tube feeding? So some of our patients, if their dysphagia is bad enough where they actually can't take anything by mouth, we might consider doing something known as enteral tube feeding. Okay, so we're giving them, broken down material through their GI tract. They're just not going to be able to swallow it. And in some cases, patients are so malnourished, or there's such an increased risk for malnutrition, that we might let them eat by mouth, but we're also going to give them enteral feedings as well, because they're not eating as much by mouth as they should be to maintain their overall nutritional status. So like we said, it's enteral nutrition that provides nutrients directly into the GI tract. Okay? It's always better to feed patients by the GI tract versus IV nutrition. So when we start talking about TPN or hyperalimentation, that will make better sense. Okay? It's just better, more physiological sound for the body. So types of enteral tubes that you might see enteral feeding. Nasogastric or nasointestinal tubes, right? Where tubes we put directly through their nose. We can feed that way. Or we're also going to see maybe some percutaneous tubes that are surgically or endoscopically placed. So these are called G tubes or J tubes. They're gastrotomy tubes. So they can either be put directly through their nose or directly through their skin, either directly into their stomach or into the small intestines. Okay. So some of our NG or NJ tubes are shorter term, whereas surgical or endoscopy placements are more longer term. So some other different classifications of feedings is we can either do it intermittently, like a bolus feeding, or we can do it continuously, 24/7. So intermittent or bolus tube feedings can be done, maybe 3 or 4 times a day, and there's a certain amount of volume we give these patients. Or we can do it continuously, maybe over a 12-hour period at night, or maybe over a 24-hour period. So it's slower. Patients typically tolerate it a little bit better when we give it slower and continuous. You're often going to see it more continuous, slow in the hospital versus you might see it intermittent bolus in a long-term care facility or at a patient who is managing themselves outpatient. Okay, so that's just where they've become accustomed. Okay, it's not feasible or realistic for those patients to continuously be hooked up to an enteral tube feeding for long periods of time. So 2 of the biggest complications with enteral tube feeding is aspiration and diarrhea. Okay. So aspiration, obviously that makes sense if patients have dysphagia to begin with, they have an altered gag reflex. Some of the large quantities of fluids that we give to these patients through the enteral route can actually reflux back, okay, especially if it's not moving forward as it should be. Increases their risk for aspiration pneumonia. So a lot of the enteral tube feedings that we use, there's multiple variations or types of tube feeding formula out there. It has a high kind of osmotic content. There's a lot of dextrose into it, and it can actually pool a lot of fluid into the bowel as it starts to move through. So it can induce diarrhea. Okay? So that's a common complication of tube feedings, especially when you're just starting. Right, so this is a picture. The one on the left is like a small bore tube feed. It's called a Dabha. You're only going to be able to feed through this. It's going to go right through the nose, and it's most likely going to end right into the stomach. Okay. The one on the right is a Salem sump, or just an NG tube, and we can use this with suction, and we can also use this with feeding. The one on the left, the smaller one, is much more comfortable for your patients, and there's less risk of aspiration because it's weighted at the end, and so the tube actually can't pull its way back. Okay, so it stays down in there, whereas the one on the right typically can migrate a little bit and pull out. So obviously the closer we're out of the stomach, the closer we are to kind of the esophagus, where it meets with the trachea up at the top, so we're increasing our patients' risk for aspiration. So here's just another slide that shows you the different types of routes for enteral access. Like we said, you can go through the nose, it can end in the stomach, it can end in the duodenum or the duodenum, it can end in the jejunum. And like we said, you can have the percutaneous directly through the skin routes. Those are more of the long term. So you can have a gastrotomy tube, which is right through the stomach. You can have the jejunostomy tube, which is right in the jejunum. So a lot of different variations. So in a few weeks, when we actually practice inserting NG tubes, there are different ways. We can do this at the bedside when we're putting in the nasogastric or the nasointestinal. We have to make sure it's in the right place. Okay, and so 2 of the most important measurements that we can use for verification of placement is the pH content of the substance that we pull back from wherever it's terminated, or a chest x-ray. The chest x-ray is the most valid verification, right? If it's in the stomach, which for your CPEs at the end, we're going to want a pH of less than 4. So when we actually insert it in, and if we're in the right place, if we put a syringe on the end and we pull back some aspirate and we actually check the pH content, it looks exactly what it does on the right, in the picture up at the right. The pH should be less than 4 if it's in the stomach. All right, so we talked about enteral nutrition, right? Directly through the GI tract. It's the best physiologically for the body. It's natural. Some of these patients just can't swallow, so they can't take anything by mouth, or they're just not able to meet their demands by the mouth. So we have to actually do an enteral feeding as well. All right, so parental nutrition, or TPN, or PPN, as we refer to it, or hyperalimentation. This is going to be nutrients that are given right through an IV. So more commonly, you're going to see this given through a central line or a PICC line. We're not going to be giving these through a peripheral IV site. And the reason is because it's very damaging to the vessels. So we need to have this in a really large vein that's more centrally located. So who qualifies for TPN or parenteral nutrition? Some of our patients who have complete bowel obstructions where we actually can't use the GI tract. Some of our patients who are so sick that we don't want to use the GI tract because they are at risk for obstructions or an ileus. So we have to use TPN. There are some patients that are born with small guts, patients who have ulcerative colitis, Crohn's. We're feeding them through the GI tract is just not optimal. Okay? TPN is not meant to be long-term, but in some severe cases it is long-term. And it's because it's very challenging to the liver, so it can actually damage the liver over long periods of time. So some of the complications that we worry about with TPN, it's nutrition in the bag. So you're having high contents of dextrose that's already broken down. Yes, there's lipids in it in some capacity, proteins, trace minerals, some of your electrolytes like potassium, magnesium, phosphorus, calcium, and in some cases we actually can put insulin directly in the TPN bag. So large in part though, there is a lot more dextrose, simple carbohydrates than it is than anything else. And so we have to kind of start it slow when we do because it increases the patient's risk for hyperglycemia. Okay? So whether these patients are diabetic or not, we're checking their blood sugars, typically every 6 hours. If you look at a TPN bag, and it's actually on the next slide, you're going to see there's a lot of volume in it. Okay, so not only does it have a higher osmotic concentration, it's very viscous, there's a lot of volume to it. Okay, so yes, we typically start it very slowly and work our way up, but these patients, not only are they at risk for high blood sugars, they're also at risk for volume overload, volume excess. Okay, so we're watching for signs and symptoms of volume overload. Obviously, we're giving these patients a lot of electrolytes, potassium, magnesium, phosphorus, calcium, over shorter periods of time. So usually every day that these patients are on TPN, or maybe it's going to be spread out longer, we're going to be evaluating their electrolyte status. What's their potassium level? All right, so this is just another picture of, on the right, it's kind of what a TPN bag looks like. And on the left is kind of the central location. We're going to see it like right in the superior vena cava before it hits the right atrium. Okay, because the medication is considered a vesicant or an irritant. And so we would fry these patients' peripheral veins if we put it peripherally for a long period of time. All right, so let's talk about medical nutrition therapy. So there's specific nutritional therapy that's used with certain illnesses, injuries, or conditions. All right, so diabetes, and we're going to talk about that week 7 in more detail. But obviously, regardless of whether it's type 1 or type 2, these patients are going to have a more controlled, consistent amount of carbohydrate intake. They have to have carbohydrates, right, because it's our most essential form of fuel. But we're going to be in a more controlled, moderate carbohydrate intake. Saturated fat, less than 7%. I think saturated fat for the overall general population is less than 10. But we're going to intake their cholesterol to less than 200 milligrams. And then we also want to maintain their protein intake between 15 to 20%. Like we said, per day. Sometimes you're going to see patients that are not on a very traditional diet. That's kind of set forth by the American Heart Association or the American Diabetes Association. But just make sure that you're focusing your attention on those, approved associations, organizations, guidelines, right? More traditional, what's in your textbook, okay? So patients who are diabetic are at increased risk for atherosclerosis, like those plaque formations within their arteries. So it makes sense, not only are we focusing on their carbohydrate intake, we're also focusing on their cholesterol and their fat because they're at increased risk for earlier atherosclerotic plaque formation. Protein intake, like we said, these patients need adequate protein intake, but we're not going to encourage these patients to be on a high protein diet. There's no validity with your patients who are diabetic. Now, however, you may see, kind of non-traditional high protein diets for patients who are diabetic. Focus on what's in your textbook. So our goals for nutrition with our patients who are diabetic: normal glucose levels. And we're going to talk about that more on week 7. What's a normal glucose level? Well, it's really relevant to the patient and what's going on with their condition and when we're checking it. Okay. Like we said, we want their cholesterol levels, LDL, HDLs to be optimal. We want their blood pressure to be on the normal to lower side because they're at increased risk for atherosclerotic plaque formation. And high blood pressure, hypertension is a precursor to that as well. But we also want to make sure that we're avoiding hypoglycemia because, like we said, these patients need carbohydrates. Probably better complex carbohydrates as well. Right, so our patients who are at cardiovascular risk, diets to manage hypertension, coronary artery disease. Well, obviously, we still want them to have a well-rounded caloric intake, meet all their nutritional needs, exercise, and definitely maintain ideal body weight, keeping their BMI between, I think it's 18 to 25. Increasing their intake of fresh fruits, vegetables. There's been some research that supports higher calcium, higher potassium levels, improve their overall risk with cardiovascular disease. We want them to eat complex carbs that are broken down slower, that have higher fiber content in it. They found to help with lipid fat absorption breakdown. We also want these patients to eat fatty fish, omega-3 fatty acids 2 to 3 times a week. Has the monosaturated fats in it. Limit their sugars, their simple sugars, their salts. We're going to talk about salt intake week 7. We talk about hypertension. Limit trans fats to less than 1% of their diet. Yeah, so processed foods, potato chips. Limit saturated fats to less than 7% as well. Where does that come from? Animal meats, butter, lards. And then limit cholesterol to less than 300 milligrams per day. So our patients with cancer who are getting cancer treatment with chemotherapy, maybe radiation to the head or neck, we know that malignant cells compete with normal cells for nutrients. And so our malignant cells, cancer cells, are much more aggressive than our normal cells, so they consume a lot of the calories and nutrients that our normal cells need. So this is why you're often going to see patients with cancers weight loss. Obviously makes sense with chemotherapy. Some of the side effects from the oral and the IV chemotherapy is nausea, vomiting. It can alter their taste. Just makes them feel like they don't want to eat. Okay, so that can be linked to the weight loss. Some of your radiation to the head and neck increases their risk for malnutrition because it can lead to irritation, inflammation within their mouth, their oral cavity. They're not going to want to eat. They're tired. Okay? So not only the malnutrition associated with cancer in itself can increase their morbidity and mortality before their time. So what are some things that we're going to do for these patients who have cancer or cancer treatments? Maximum fluid and nutrient intake. Okay? Obviously individualizing it to the patient and their needs, but we're going to encourage small, frequent meals with high calorie content and snacks in between. And we might encourage some of the supplement liquids like Glucerna, okay? Some of the high calorie supplements. But small, frequent meals, what the patient wants. So your patient who have HIV/AIDS, right? These patients also have body wasting and severe weight loss, and that condition is cachexia. They look cachexic. Okay? And it's multifactorial, right? Is it related to their overall increased metabolic rate? Is it also related to the antiretrovirals that these patients are on? Some of the side effects of the antiretrovirals, the cocktails, are worse than the disease itself. Okay? So what's our goal for these patients as well? Obviously maximizing their calories and their nutrients. Again, like cancer patients, encourage small, frequent meals, nutrient-dense meals, and we're going to encourage them to intake fluid in between, not with our meals. We don't want them to uptake their meals with fluids so that way they're not hungry, that they're not eating the caloric, nutrient-dense meals, the foods. Right, so patients who have peptic ulcers or they're at risk for peptic ulcers, we know some of the biggest risk factors for peptic ulcers, bacteria known as H. pylori or Helicobacter pylori. About 80 to 90% of all patients who have peptic ulcer, it's related to this bacteria. It can also be linked to stress, overproduction of hydrochloric acid. But our patients who have peptic ulcers, we want to do everything we can to minimize any more irritation that's going along the lining of our stomach. Okay? Erosion, increase in acid production. We want to minimize that. So, we may want to minimize caffeine in the form of coffee, colas, some teas, avoiding spicy foods, any types of irritants that's going to stimulate hydrochloric acid production. With these situations, we're going to avoid any aspirin NSAIDs. They can induce GI irritability, but not only that, they increase the patient's risk for not clotting, increasing their bleeding risk. So these patients, we might encourage them to consume small, frequent meals, maybe bland, more tolerable foods. And then diverticulitis, inflammation of the diverticuli. So what are diverticuli? Well, they're not normal, that's for sure. So our patients who are at long-term risk with constipation, increased or decreased transit time. So these little outpouchings within the colon, where the large intestines called diverticuli, can form when patients have frequent constipation, where things aren't moving through. These little outpouchings can occur. And so what can happen over time is, depending on what the food intake these patients are consuming, some little seeds or nuts can actually get caught in these diverticuli and cause them to become irritated, inflamed, and actually infected. And then that becomes diverticulitis. Okay? Those little diverticuli that have become inflamed, irritated, can actually perforate and lead to a condition known as peritonitis. Okay? It can lead to abscesses. You see that giant diverticulum? Okay, that's huge. So if these patients don't have an active infection like diverticulitis, we want to encourage anything that's going to avoid constipation, right? So fresh fruits and vegetables, high fiber. That's what these patients need to increase their decrease their transient time. So the time it takes from the time we swallow, we want to increase that time. So we don't want it to be sitting in the gut, hold up, right? So we want to move things through. So high fiber. If the patient actually has an active inflammation infection, initially we might not even feed these patients. But if they do start them, they're going to start them very slow, and they're probably going to put them on a very low residue diet until the inflammation, the infection resolves. So in addition, if these patients have a diverticula, in addition to the high fiber, increased fluid intake, we want them to limit diets that have no seeds to it. So strawberries, blackberries, raspberries, some nuts, watermelons, things like that. You need to minimize seeds, increase high fiber water intake to minimize constipation, and increase their transient time, or improve their transient time.